Now this particular case, we've done the left side with balloon elevation, and we can see the post-op CT before and after. We can see very nicely the shape of the balloon elevated sinus, and we are talking about the right side, which needs both ridge splitting because of the narrow ridge. We have about 2.8 millimeter width of the ridge, and we need also a sinus elevation because we have about 3 millimeters of remaining alveolar bone height. So we would start first by doing our incision and flap elevation. We are going to use the MIAMBI minimally invasive antral balloon elevation system. We have the pump which controls the pressure of the balloon elevation, and we have tubing and also contrast fluid that will give us the exact elevation of the Schneiderian membrane while doing the treatment. So the system is comprised of a tubing with a balloon. The balloon is elevated at the beginning of the treatment in order to check that the balloon is intact. And after checking the balloon and the tubing system, we are ready to go ahead and do our procedure. So we start first by doing our flap elevation. We are using mid-crestal incision with small vertical incisions, preserving the papillas. The flap should not be too much extended. We are not going all the way to the mucogingival junction. Only small minor vertical incision just to reflect the underneath ridge. So we are elevating the flap, and we are starting to do our splitting with ultrasonic bone device. This is a very sharp, narrow instrument, 0.3 millimeter in diameter, made by piezosurgery, and we are now splitting the ridge, going all the way in. And in order to gain more flexibility, we are doing also some vertical cuts with our surgical device, and this will give us more flexibility of the ridge. We are working with chisels to spread a little bit the buccal from the lingual plate, and now we go with manual expanders, and we are expanding the ridge, shifting the buccal plate from the palatal plate. And by using those manual spreaders, we can gain ridge width starting from 2.8 to about 7 or even 8 millimeters, as you will see in a few minutes. So we are separating now the two bony plates, and this will give us the ability to go ahead and insert immediately our implants. So we go ahead and we use our final drills for the osteotomy. We will pick up the desired implant, and the implant will be inserted between the buccal and lingual plates. We manually insert the implant all the way in, and we are able now to insert the second implant as well. And you can note that we have preserved the buccal plate, and we have at least 1.5 millimeters of width of the buccal plate. In order to fill the gaps between the implants. We are using xenograft as our grafting material. This is the endobone here, which is used to fill up the defect and the voids in between those two implants. Material is packed around the implants, and right now we can move ahead to the distal portion, where initially we aim to place two implants in the sinus area with sinus augmentation, and we are using here minimally invasive antral balloon elevation. We do our initial preparation with ultrasonic bone device, reaching almost to the sinus membrane. We go approximately 1 millimeter from the sinus floor, and then we will infracture the sinus floor. Of course, we know according to the pre-measurements on the CT scan exactly where we are. We are placing a small amount of grafting material which serves as a cushion, and then we will infracture the sinus floor with a specifically designed osteotome, 2.9 millimeters in diameter. The next stage is to introduce the balloon. The balloon is incorporated in a metal tube, and we have Teflon stoppers correlating to the amount of bone which is present. We start to elevate, and we check the pressure on our pump, and when it reaches the pressure of about 0.5 to 2 atmospheres, the pressure starts to decrease and go down until 0.5 atmospheres, and that shows us that the balloon has inflated, and we can see very clearly how it inflates along the septa of the sinus. Then we pack the osteotomy site with our bone material, and we have a specific injector which correlates to the diameter of the osteotomy, and an implant, of course, is inserted at the same time. And we will see shortly in a post-op periapical X-ray how the implant is surrounded by bone. Then we go ahead and we inject other material to the anterior osteotomy that was done with the balloon. We introduce the material, and again placing our implant all the way in. And we will see again on the periapical X-ray how the implant is surrounded by bone after the balloon elevation. Of course, that by using the balloon elevation we need much less grafting material, and of course no membrane are needed. We add some more of grafting material and a resorbable collagen membrane, just to make sure that we didn't have any micro cracks where we did the ridge splitting, and then we go for primary closure with no tension, tension-free closure. Flaps are closed, and the patient is released, given post-op instructions.
Click.